We are going to learn about interstitial lung diseases and their radiological appearance, mainly using CT, and we'll also see pathology associated with interstitial lung disease in this video. Before we move to the disease, first let's know the anatomy of a secondary pulmonary lobule. This is the smallest unit which is visible on HRCT imaging. Whereas smallest unit of lung is alveoli as per histology, but this is the smallest unit which can be visualized by HRCT. Now secondary pulmonary lobule is supplied by lobular bronchus and lobular artery. Next, which will divide into terminal bronchiole, and further after branching the continuation is called respiratory bronchioles, and each branch is called acinar bronchiole with associated acinar artery. This will supply one acinus. This is one secondary pulmonary lobule which is visible on HRCT, and it's 1 centimeter in size. And along the margins or the borders of secondary pulmonary lobule, its interlobular septa, which is 0.1 millimeter thick, and along which the pulmonary veins and lymphatics will pass through. So interlobular septa contains pulmonary vein or venules, connective tissue and lymphatics. This will constitute the interstitium. So affecting these are the interstitial lung diseases. So what all patterns can the interstitial lung disease present with? It can present with lesions which have increased lung attenuation, like ground glass opacities, also known as GGOs, and consolidations. So the difference between ground glass and consolidation is consolidation has obscured vascular markings and GGOs can show vascular markings through it. Then there are lesions with decreased lung attenuation. So these can be peripheral multilayered cystic changes, those are called as honeycombing, dilated bronchioles and bronchi called bronchiectasis, emphysematous changes or lung cysts or pneumatoceles. These are the lesions with decreased lung attenuation. Some interstitial lung diseases also present with nodules and linear or reticular opacities. Linear opacities are nothing but interlobular septal thickening. Now let's classify the interstitial lung diseases. So first are the idiopathic interstitial lung diseases. First is the usual interstitial pneumonia, also known as UIP. Next is the non-specific interstitial pneumonia, called as NSIP. Next, respiratory bronchiolitis, desquamative interstitial pneumonia, cryptogenic organizing pneumonia, also known as COP. Next is acute interstitial pneumonia. There are interstitial lung diseases with known causes also. First is the sarcoidosis affecting the interstitium. Next is the connective tissue disorders like rheumatoid arthritis, systemic sclerosis, systemic lupus erythematosus in acute and chronic form, hypersensitivity pneumonitis. This also can be acute, subacute or chronic. Next is silicosis. Next we have lymphangioliomyomatosis and Langerhans cell histiocytosis. The last one we have pulmonary alveolar proteinosis. All these can cause interstitial lung diseases. Next, we also have some miscellaneous causes which we'll see. The miscellaneous causes include infective, under which comes viral pneumonias, pneumocystis carinii pneumonia and mycoplasma pneumonias, and non-infective causes which include eosinophilic pneumonia, acute respiratory distress syndrome, lipoid pneumonia and diffuse alveolar hemorrhage. In this video, we'll discuss only idiopathic interstitial lung diseases. First being idiopathic pulmonary fibrosis, which presents as usual interstitial pneumonia. This has an apico-basal gradient, meaning more so in the basal region. It presents with honeycombing, traction bronchiectasis, reticular opacities which are subpleural in nature, and volume loss may or may not be present. So in this coronary CT image, we can see honeycombing, traction bronchiectasis, subpleural reticular opacities, and the apico-basal gradient. More of the diseases affecting the basal segments. Usual interstitial pneumonia is classified into subtypes. There is typical UIP in which the basal peripheral gradient is present. This has reticular opacities and traction bronchiectasis, and more importantly honeycombing. Honeycombing, if it's present, it is typical UIP for sure. There will be absence of other diagnosis also. In probable UIP, there will be basal and peripheral gradient obviously present, reticular opacity is present, and traction bronchiectasis present, and there is no honeycombing in this, and there is absence of alternate diagnosis. So traction bronchiectasis alone is probable UIP. In indeterminate for UIP cases, there will be basal or diffuse gradient, subtle reticulations, ground glass opacities. So only reticular opacities are present. It is indeterminate for UIP. What is the treatment for UIP? Cyclosporin and corticosteroids will cause symptomatic relief and reduce disease progression in acute exacerbations. Moving on to non-specific interstitial pneumonia, the gradient here is central sparing with peripheral opacities, but there will be immediate subpleural sparing. More commonly, we see ground glass opacities, reticular opacities, and micronodules in this. Micro honeycombing can be seen in advanced cases, but very classical feature of NSIP is immediate subpleural sparing. There is a thin line of normal lung tissue present. Axial HRCT image, here we can see reticular opacities, ground glass opacities, and micronodules. This is an advanced disease where the whole lung is affected. Classically, here we can see subpleural sparing, where a normal lung tissue is present beneath the pleura. Histologically, there are two types of NSIPs. One is the cellular type and next one is the fibrosing type. Treatment is corticosteroids or cytotoxic drugs like cyclophosphamide, cyclosporin, etc. and treatment works better in cellular type of disease. Just to revise the difference between UIP and NSIP, UIP has an apico-basal gradient, NSIP has no gradient. UIP is heterogeneous opacities, here it is homogeneous. Honeycombing is classic for UIP, pathognomic, and GGO is pathognomic for NSIP. UIP has traction bronchiectasis, NSIP has micronodules. Next we have the cryptogenic organizing pneumonia, which has no association with smoking, more commonly found in non-smoker. This is a very important point to remember. And the opacities are usually peripheral and peribronchial in nature. They have slight basal predominance. So what all are the opacities we see here? We see ground glass opacities and consolidation. Ground glass opacities later, if untreated, will progress to consolidation. There can be mild cylindrical bronchiectasis because of peribronchial opacities. Classic for this disease is migrating opacities and no response to antibiotics. So axial HRCT sections, we can see peribronchial consolidations, and classically we have migrating consolidations in COP. There can be ground glass opacities also. Coming to another important part, smoking related interstitial lung diseases, there is respiratory bronchiolitis associated ILD, where smoking is average of 30 pack years of these patients, and then smoking cessation is an important part of the treatment. There will be pigmented macrophages deposition in respiratory bronchioles. Desquamative interstitial pneumonia is the other entity where it is said to be end spectrum of RBILD. There will be diffuse accumulation of macrophages, hence a diffuse disease. Distribution of respiratory bronchiolitis is more commonly upper lobe, and more common opacity is ground glass opacities with some centrilobular nodules. Here we can see upper lobe predominant ground glass opacities and some centrilobular nodules. Next, desquamative interstitial pneumonia is a diffuse disease affecting peripheral aspects of lung. Opacities seen here are ground glass opacities with some reticular opacities in subpleural region. Here you can see some cystic changes are also seen in advanced diseases. Next we have acute interstitial pneumonia. It's of course idiopathic. Pathology is there will be diffuse alveolar damage with lower lung predominance and there will be bilateral symmetrical opacities. In early exudative phase of this disease, we can see ground glass opacities progressing to consolidation. Next, in chronic organizing phase, there will be changes like honeycombing and traction bronchiectasis, which are the end spectrum of this disease. Here are some key points to know before reporting cases of ILDs on HRCT. Idiopathic interstitial lung diseases are rare, so rule out the known causes like rheumatoid SLE, systemic sclerosis, etc. Classification of ILDs is based on histology, not imaging. The imaging patterns are just closely associated with histological findings like macrophages deposition in RB is a pathology. Centrilobular nodules appear on imaging, seen in respiratory bronchiolitis. Just centrilobular nodules are non-specific, so correlate with histology. Follow-up scan is required because it's a dynamic diagnosis. HRCT chest is the imaging of choice. Surgical lung biopsy confirms our imaging diagnosis. While taking biopsy, we have to take biopsy samples from more than one lobe. And response to corticosteroid, which is the mainstay of treatment, is seen best in cryptogenic organizing pneumonia. For more such videos, please follow our channel on YouTube and Instagram at Radiology Doodles. Thank you.